milligrams of flumazenil. 0.2 milligrams.
And this was into the IV again,
Straight
or into him?
Into the IV.
Okay.
Into the IV. And continue to do chest compression to circulate the medication. Hopefully it will help if his respiratory status was depressed. It will reverse the effect of the medication, and he will try to breathe. But he still will not breathe.
And no help's coming.
No help is coming. So I now did chest compression, did small to moderate resuscitation again, enough to make sure that he was well ventilated. Chest compression was there. Opened the door, ran out, and went left on the second level down towards the kitchen where security would be. And when I got to the bottom of the stairs, I saw the chef who was cooking. I think her name is Rose. And I told her I had an emergency, have security come immediately. And that's when the gentleman you hear on the 911 call comes upstairs. The door is open, he gets inside there. I said call 911. While he's doing 911, I am doing chest compressions, I'm doing mouth-to-mouth resuscitation, but I want 911 to be called now, even though he's still on the bed, because I will still need help to move him up from the bed and place him at an appropriate site on the floor where I would have a firmer surface. So I continue to support his back when I do the chest compressions. I continue to ventilate him with my mouth. The operator is asking the security guard what's going on. They say we have a patient that is not breathing. That's all of the things he's saying he's getting from me. How old is he? I said 50 years because they don't know his age.
Do you know who the security guard was?
Alberto Alvarez. And the operators continued to ask questions, and I said just tell him to get here, because I wanted him to come down and help me move him to a harder surface so we can do CPR and ventilate him. And so the operator said that they were on the way, so he put the phone down, he came then to the bedside, removed the patient to the floor, which was what I wanted to do. And then I continued to do CPR and mouth-to-mouth resuscitation until paramedics came. When paramedics came, they called UCLA, they hooked him up to the pulse oximeter. He was not breathing, we were doing chest compression, we were bagging him, we got him intubated. We also realized that his rhythm was what we call PEA. PEA?
Yeah. What's that?
Pulseless electrical activity.
Pulseless
electrical activity. This is where you have a heartbeat that is electrically seen, but every time the beat of you see the beat, the heart does not contract to push a pulse. The treatment of that is never to shock the patient. So there was no reason to shock him. You shock for conditions like ventricular fibrillation, ventricular tachycardia, in such state, but with PEA, you never shock. You treat the underlying condition. So he got medicines as called in by UCLA, atropine, epinephrine. I then encouraged them to consider bicarbonate, which is because I would believe that at this time he would have some acidemia. Acid meaning that not getting as much oxygen, your blood pH will go down. So I asked for bicarbonate to help him metabolically while we continued to do CPR to start an IV, which was done. The paramedics fought for a while to get an IV. Why?
Trying to find a vein.
Vein is difficult, Mr. Jackson. And in the process of moving him, my IV site became dislodged.
Now, real quick, when you talked about there's no need to shock him, did they do it against your wishes? Did the paramedics shock him?
No.
Okay.
No.
Okay.
So he was never shocked?
No, never.
The defibrillator was never used?
Never. There was no indication. I'm a cardiologist, I know that. So,
and did they give him that bicarbonate stuff?
yes,
Okay.
the UCLA agreed to give him some bicarbonate. They agreed for the epinephrine, the atropine, but whoever was the doctor at UCLA giving orders, they were kind of slow. Slow status. And then they thought that they don't have an IV access easily, made things worse, and they had to search for IV sites every day, so that needles and everything else. So basically, Mr. Jackson, after about 20 minutes of an effort, which I think was limited, because his condition was almost, I would say, witness, in the sense that I had not gone for a long time before I got back to bed. It was just so short. I would call that a witness state. And I started CPR and everything right away. It was effective, it was deep. I knew that I could feel femoral pulses with my compressions. I knew that his circulation was intact, was kept going with my effort. I then asked UCLA to transfer the care to me. And they say, so instead of calling him dead, because they figured nothing was working at the time, and they didn't think that they would be able to get him back, they said that the doctor wants to try, if I would accept the care, they would be fine, because the doctor didn't want to spend too much longer on the line trying to give medication. I figured that I wanted to give him the best effort.
So all of this is going on is you're caring for him with the paramedics' help on the floor at the house. Nothing in the ambulance yet.
No.
Okay. And they want to give up, and you don't want to give up, so they transfer care to you.
Yeah. Okay. I mean, I love Mr. Jackson. He was my friend, and he opened up to me in different ways, and I wanted to help him as much as I can. I know he was a single parent. You don't always hear that from a man, but he would state that he was a single parent of 3, and I always thought about his children, as I was thinking about mine. So I wanted to give him the best chance. So I
relinquish the responsibility.
Relinquish the responsibility to me.
Okay.
I continued CPR, epinephrine, atropine, bicarbonate, IV access, fluid was going, and we did chest compressions all the way into the ambulance. And I told him that I'm transporting him to the UCLA. I was in the ambulance with Mr. Jackson. We got to UCLA. We took him into the operating suite, where there was a host of medical personnel working to assist him. And we tried. We tried for at least an hour. And I think they may have given up earlier, hadn't I been insisting and giving him every opportunity. And then they finally decided that they will try a balloon pump on him, which was a device that placed up the aorta through the artery, and it would pump the heart during diastole, or when the heart in between beats, and push oxygenated blood back to his lungs, to his heart. I asked the cardiologist to say, do you think that would be effective? He said he had done it before, and he had good results. I said, then fine. It's not something that I would do, because I don't think balloon pumps help you if there's no blood pressure. But he wanted to try, and I was willing to give him any effort that was necessary, so I said, proceed. So he, after everything was done for Mr. Jackson, we just could not get a blood gas. The first blood gas came back, and the PO2, which is the oxygen pressure, was in the 20s. And then they thought it was venous. And then I asked them to repeat it after they got the arterial line, and then we could see that the blood was red. But the other blood gas came back with a PO2 of about in the 30s. So then...
Which is better, 20s or the 30s?
It should be in the 70s to 90s. So it's low, but 30 is better than 25.
Okay.
And I was wondering at that time, why would the CO2, which is carbon dioxide, it's in the 50s, and the normal is about, this pH is down to like 7.2, we expect him to be acidotic. Why couldn't re-get his oxygen up. So at that time, when we called the code, the doctor said, she can explain. And I said, I don't have an explanation either, but we cannot rule out the possibility of pulmonary embolism.
And now what is a pulmonary embolism?
A pulmonary embolism is a blood clot that goes to the lungs and prevents any kind of oxygenated blood to go to the lung where oxygenation takes place so blood can be exchanged with the tissue. A massive pulmonary embolism will shut down all circulation to the lungs. I will give you that picture. I could also give you pulseless electrical activity. That's why we did not have to shock his heart. So,
real quick, sorry to interrupt, real quick. When you arrive at UCLA, does I'm not sure, I'm not familiar with the rules, does the care of him transfer back to UCLA Hospital, or it stays with you?
He transfers back to UCLA.
Okay.
But I don't have privileges.
Okay.
But I stayed in the area, and it allowed me to do that, in the periphery. And I made suggestions, and they were amenable to that. And then subsequently the cardiologist came who tried the balloon pump.
Can I, would you guys mind if I add a little bit?
No, not at all.
One of the things that, the difference is here is despite the fact that Mr. Jackson was using this drug to sleep, I guess, for a long time, there was a change in his drug intake for 3 days prior to his death. And would you explain why that was? I don't think we got to that.
No, not yet.
Okay, before we get there, obviously, inevitably, things happen. And
He passed. They pronounced him. And at that time, I recommended. I am the one that recommended. They said, well, is there a doctor who's going to sign a death certificate? And I said, I wouldn't want to sign a death certificate on Mr. Jackson when I don't understand the cause of his death. And therefore I recommended that he have an autopsy. That's where the recommendation came from.
Yeah, we've been told by different sources that is what happened.
I recommended it.
Yes.
All right, just tell him what happened the 3 days prior, please.
Yeah. Mr. Jackson was my friend. I loved him, and we had a good relationship. And after joining his team, I fell into the situation of a gentleman who wanted a regular, frequently, nightly Deprovan. That was not my purpose of joining this team. I was there to help him, and I was going to be available should something go wrong. I had to provide the best care for him. That was frustrating to me. And after I saw that this could be a habit, which I did not recognize before, but not being with him all the time, it was not natural. I then tried to help Mr. Jackson. I was trying to wean him off the propofol. But like everything else, you have to look at behavior pattern. I had not seen any study where someone was addicted to that medication, because it's always used in some situation where one doesn't have to get it so frequently. But if you got accustomed to any agent that is studied in that way, you definitely may see that there could be dependency. So with cautiousness again, I was concerned how it was difficult to get him to sleep that night, and could not tell if that was a withdrawal effect from what he was accustomed to. Why did I come to that conclusion? 3 days before,